Hello and welcome to a new week of our Breast Cancer Awareness Month here on the Joy Super Morning Show. My name is Kojo Akoto Boateng, and we have Professor Kafui Akakpo back. You remember when we started the series, he started us off by explaining a lot about cancers to us. And today he's back for us to talk about breast cancers. And we are going to talk about breast cancers from the pathology perspective. And the truth is, breast cancers informed our Cancer Awareness Month programming, because we all know that in the month of October, there's a lot of awareness about breast cancers. But we decided that instead of talking about breast cancers alone in the month of October, we are going to spread it and talk about cancers in general. So we themed each week to be able to talk about a set of cancers and get all of us the knowledge and the education to help us fight cancers in the country. So we've come to the reason why we started the Cancer Awareness Month, and I'm so happy to have Professor Kafui Akakpo back with us on the show to talk about breast cancers, to give us the pathology perspective. Prof, welcome back to the show.
Thank you very much for having me again.
It's good to have you again, and it's good to learn new things from you. At least from this series, I have learned that we have anatomic pathologists, and you are one of them. Now, let's talk about breast cancer. It's one of the cancers that a lot of us feel that we know a lot about because of the October education and the October activism. But I'm sure there's a lot more we can learn today about breast cancers to give us a complete knowledge of the cancer to help all of us fight it. So please share some insights on the natural history of breast cancer. What is breast cancer? What is the history of breast cancer, and why are we here?
Thank you very much. So, just as a point of information, breast cancer is the commonest cancer in women now. It leads cervical cancer. So it's common in our people. And as the name suggests, it's cancer that occurs in the breast, which means you have an abnormal growth that is occurring in the breast. Black people don't tend to have as many cancers, breast cancers, as white people. However, when we do have breast cancer, it tends to be aggressive. And again, the types of breast cancer that we have usually are not the ones that usually respond to targeted therapy and the new treatments that are coming. It is because we have a specific biology, which means that we also have our own kind of breast cancers that require a certain kind of treatment. However, the good thing about it is that if you find a breast cancer early in our people, the outlook is similar to breast cancer that is found in a white person who is staying in America. So the key is to find it early.
But how does breast cancers develop?
So thank you for that question. That's a very good question. In the recent engagements that we had, I mentioned that there are risk factors for getting cancers. And breast cancer does have risk factors. Some of the risk factors we discussed before include your sex is one. Females tend to have more breast cancers than males. Obesity is something that can predispose you to breast cancer. Early menarche, which means that when you have your menses at an earlier age, but you don't have children early, or you have late menopause, it gives you prolonged exposure to estrogen, and that is a risk factor. Some people have breast cancer that runs in families, so it means that genes can predispose you to breast cancer, but they form a small proportion. Then people who have had previous breast cancers can also have breast cancer. Now, when you put these together, you notice that these are things that you really can't do much about. So there are things that you can do something about and see if you can prevent the breast cancer, but there are those that you can't do much about. And so when it comes to those risk factors, it's not modifiable. But of course, some people also say that you can have modifiable risk factors like exercising, so that you will not be obese. These things, eating a good diet and staying healthy in general. These are believed to be things that you can modify, and therefore they can prevent you from or reduce your risk of having breast cancer. However, all these aside, that is taking the avoiding the risk factors or putting the risk factors aside, what you notice is that this breast cancer starts out as what they call ductal carcinoma in situ. Now, excuse me for the long word, but basically what it means is that your breast cancer cells that produce the milk, or which are supposed to be the cells that produce the milk, begin to grow a little faster than they should grow out of the usual. And instead of your body recognizing that they are growing a little too fast and therefore those ones should be removed, they persist. And so you have an increase in the proportion of cells that line the tubes that produce milk in your breast. And as this goes on, it gets to that point where those cells at a certain point in time have the ability to not only grow within the tubes, but go outside of the tubes into the supporting meshwork of your breast. And what supports your breast are the blood vessels, the fibrocollagenous tissue, the fat, and all those other cells that are not supposed to be producing milk, but just holds the breast together. So once you have that invasive nature of it, that's the ductal carcinoma going into those cells, that's when you see you've got an invasive breast cancer. It means the cancer has moved from the lumen of the duct into the stroma. When the cancer gets into the stroma, what it means is that it has become a tumor that can go into your blood vessels and your lymphatic vessels. And that means that it can also begin to leave the breast. And that is when you see that the breast cancer has metastasized. Now, the good thing about early breast cancer, DCIS, is that when the process starts, you've got some changes that you can pick on imaging. So the radiologist will tell you that they can see some calcifications which are unusual. And that's why when they do a mammogram, they can see those calcifications. And once they see those calcifications, they can take biopsies of them, which we can look at under the microscope and say, you know what, there's a process that is starting. So it is good that you remove that tube or duct that has got that problem in it. And that is the basis of breast cancer screening. Now, if this fails and the tumor goes into the stroma, then you have early breast cancer, and then it moves on. And of course, it's an exponential growth. So you have the thing multiplying in large groups over a period. So the longer you wait, the more likely it is that it will become bigger. And the more it grows and becomes larger, then you get a subclone of cells that have the ability to recognize these vessels and therefore move on to your lymph nodes and to other places. So it's the size of the tumor matters a lot when it comes to the chances that you have got metastasis or you've got tumor that has gone outside of the breast. And it also affects the outcome of the disease and even the treatment that you get. It's the stages relate to the size and the extent to which the tumor has spread within the breast into the regional lymph nodes and outside of the breast altogether into another structure, like let's say the lungs or into the brain.
Prof, you've said a lot of things, and I feel like we are in an anatomy class. So let me see if I understand all that you're saying. And correct me if I didn't get it right. So the breast cancers are likely form in the channels where breast milk is produced.
Yes.
And
So
if we don't find it, it gets into, you use expressions like stroma, calcification, and all those things. So the first thing I heard is that the breast cancer begins from the cells where breast milk is produced, number one. The other thing I heard is that people at risk are people who have early menstruations, because then there is the hormone estrogen in the right quantities or in large quantities in your body. And people who have late, if you have an early menstruation, you don't give birth early, and then people who have late menopause.
late menopause.
So I got those. So What is the stroma and the calcification? For those of us who didn't go to medical school, what are those things?
So if you take the breast looks like if you have grapes, the grapes that you have the core on it, and the grapes are attached to the core, which is the what holds the grapes together. So the lobules are the grape itself, and the core of it, that duct, is what holds all those bunch of grapes together.
Okay.
And all these small grapes produce the milk, and eventually that milk goes into the core and eventually appears at the nipple. So what it means is that those grapes contain cells, and these cells are the ones that are designed to produce milk. Their terminal role is that they should be producing milk. Now,
so Prof, again, I want to see if I understand this. So the breast is like a bunch of grapes covered by a skin, and all these individual grapes produce milk that goes through a central duct that pushes the milk to the nipple.
Exactly.
Okay.
So
now I'm with you.
So what it means is that you've got a lot of cells that are in little pockets, round tubes, all clustering and producing milk within the breast, and finally coming to the nipple to release the milk. Now, this is for somebody who is producing milk, but the process starts much earlier. At a certain age, a hormone would come in and start preparing the breast for this role, and that is estrogen. What it means is that when you have early menstruation, you would have your breasts starting to develop in preparation for that ultimate process of producing milk. Now, if that process does not immediately take place, what happens is that your cells have not terminally differentiated into their role yet. So the cells are in waiting to terminally differentiate into producing milk. And the more exposure you have to that estrogen without the terminal differentiation occurring, the more likely it is that those cells can start growing rather fast. And some of those rogue cells are the ones that eventually result in the breast cancer. So what it means is that for those who have fewer children, who have them late, and also go on to have late menopause, there is a risk that they may get breast cancer. Of course, this is within the context of all other risks that I have mentioned. Like I mentioned, obesity, family association, you've got a previous lesion that is malignant in your breast. These are all other risks that come together and then increase your chances of getting the breast cancer. So it starts out as changes that occur within the small ducts. And then these changes, because the cells are dividing at a very fast rate, eventually these cells can clog even the tubes, and then some of those cells die. When those cells die, they cause some bit of necrosis, which I'm sure you understand, like cell death. Yeah. Now, out of that, you have calcifications. You have this hard thing. It's like chalk, but it's calcified, and those begin to appear within the ducts. That is what the radiologist can also pick as part of
the calcification. Is it like sometimes when skin cells die on our body and pile up and you become some hard body on the skin?
The best thing to use to describe it is when you have plaque between your teeth. You have this thing that feels a bit like hardish. Yes. So that's how the calcified material looks like. It's a bit hard, and that is, it can show on X-ray. So when they do their imaging, that's the right word for it, for mammograms, they can see these calcifications, and that is one that tells them that there may be changes that are going on within the little tubes that are supposed to be the milk-producing tubes. So if that is seen at that stage, a biopsy can be done, and once confirmed, it means that you just have a small bit of the breast that is involved, and once that is taken out, you're good to go. And that forms the basis of screening. However, if that does not occur, then it goes outside of the ducts. Because the ducts are tubes, that are lined by cells. In fact, they have another rim of cells that ensures that the cells within the center never penetrate those tubes and go outside, because the stroma is rich in supporting tissue. And when I use stroma, I use it in the sense of, if you go into a home, the human beings are the most important cells that are in the home. That's what you call the functional unit of the house. The humans, they own the house. So in the case of the breast, you got what they call the terminal duct lobular units. They own the breast. However, they require support to live. And the support includes things like blood vessels, fat, your collagen, fibrous tissue. Just like in your house, you've got a TV, you've got a chair, you've got a fan, you've got ACs and all that. So those are the supporting tissue or meshwork in there. Now, when the cells that are in the house go, you take everything apart. You destroy the things that are in your house, your chair, your TV, and then eventually it gets to that point where you actually can leave the house through the window, because you realize suddenly that the house is restrictive. You need to go outside. So you can just go out into, let's use a good example of the plumbing system, because you know the plumbing actually ends up farther than even going out of the window. So you can use the plumbing system and probably end up in a crack. And your plumbing system is your blood vessels and your lymphatics. It goes everywhere in your body, into your heart. It goes to your brain and all that. So once the cells leave that stroma and they get into the lymphatics or the blood vessels, or what I am using as a plumbing system, all they need to do is to be in the blood, and then the blood will carry them to any other place. And once they get to that new place, they establish growth again, and then they start growing again. And of course, it is difficult to allow anything else to grow in another part of your body, like your brain. There's no space for an additional tumor to grow, because the size alone is a problem. There's no additional space to accommodate any space occupying lesion again in your brain. And that is what we call metastasis. So that is how it starts. It starts from this very small changes, these small changes that occur within the ducts and lobules of your breast. And eventually, that ductal carcinoma inside you goes beyond the ducts and becomes what they call invasive carcinoma, which means it goes into the stroma. Then finally, it goes into your lymphatics. That means that it goes into the lymph nodes. And once it goes into the lymph nodes, it goes into your vessels, and then you get that becoming metastatic and going to other organs like your brain. Now, the lymph nodes are not difficult to recognize. These are small swellings that used to occur in our groin when we were children. You went to go and play football and you hurt your feet. Sometimes you have these little swellings that occur in your groin, or sometimes even under your chin when you have eaten something and one of your you have a toothache somewhere. You would notice that you have some swellings under your chin. These are
we used to call it watch a jaw.
Good. That's what they say. Yes, exactly. So these nodes drain excess fluid that forms when you have a swelling. Like when you have inflammation, you produce a lot of fluid, and that fluid is a little more than usual because you have hurt yourself and there's inflammation. The place it's full of fluid. So these nodes would drain those ones as excess and send them back to the heart. So the tumor cells would use that passage and go into those small swellings, those lymph nodes. And once they get in there, the ultimate end of whatever is in the lymph node is actually the heart, and then back into the systemic circulation. So it's a very good way of establishing growth elsewhere, because you go into the lymph node, go into the heart, and eventually you spread across the body.
So once it gets into the heart, then it's in the blood system. So now it can go to every part of
it. It goes everywhere. It can just disseminate. And that is a late stage, because at that point, you cannot say that you're going to uproot the tumor anymore with any surgical method. Effectively, you can't take out all the organs that you find the tumor in. But if it is at the early stage, when it is localized in the breast, depending on its size, even if it's very small, you can actually take out a small bit of the breast and you should be fine. If it's in the breast but slightly larger, you can take out a large chunk of the breast and you'll still be fine. And finally, if you think the thing has involved the whole breast, you can actually take out the whole breast and also go on and take out some of those lymph nodes or all the lymph nodes that matter and look at them and see if there's tumor in them. And the pathologist does that. Once you have taken the sample, the pathologist will look at it and say, oh, your surgery is adequate. You've done a good job. Everything is fine. You took out everything. If you take the lymph nodes, the pathologist will also look at the lymph nodes and say, you know what, you took out the lymph nodes. I've looked at all the lymph nodes. There's no tumor in the lymph nodes. Everything is fine. Of course, if there's tumor in the lymph nodes, he will tell you that there's tumor in the lymph nodes. So the person's disease has gone a bit late. So you need to do a little more. Give the person a bit more treatment because the tumor has gone elsewhere. You need to give more systemic treatment. In that case, what you are saying is you're targeting the blood. You're giving a lot more systemic treatment that should have an effect on the entire system and not just the local site.
Yeah. Now,
So that's the progression.
how long does it typically take for a small tumor to become large and then spread to other parts of the body?
Good question. So I mentioned grading on the first day when we had the first encounter. I mentioned to you that for every tumor, we will grade it. And I said that we would look at it in the context of a cat and we say this tumor is going to behave like a house cat and that one is going to behave like a tiger. The house cat type of breast cancers take a longer time. So you could take 2 years before you see that swelling that you noticed has become more concerning. It's growing bigger, but it's very slow. But when you have a breast cancer that is on the tiger type, it doesn't take 6 months for you to notice that the thing has ulcerated your breast. So it actually depends on the type of breast cancer you have. And because you don't know about it, what it means is that when you see the lump, you quickly have to check because you don't know whether it's the house cat type of lump you have in your breast or is the tiger type of lump that you have in your breast. But the very aggressive tumors, which is a triple negative type breast cancer, they tend to grow very fast. And it would not take you a year before you notice that it's completely taken over your breast and has changed it. And there are many changes that the clinicians, the surgeon can tell you. It will alter your nipple, it will ulcerate the breast itself. The breast itself begins to look like a peel of an orange. These are changes that you see. Then it does not move again. So you would begin to notice that physically there are a lot of changes that are going on in your breast and it just doesn't look the same anymore. And at that stage, when you have those major physical changes going on, what it means is that your stage is late. When we say stage is late, I explain that I mean that the extent to which the disease has eaten your breast is small. So late stage means the disease has eaten more of your breast or your body. Early stage means it's not done much to your breast yet. So you are in stage 1, it's good. But the moment you start talking about, oh, it's gone to stage 4, then it means it's taken over the entire breast and probably gone elsewhere in the body too. And they found that there are deposits that are in the lungs or liver, and that's why they are saying that. And of course, when it ulcerates your breast, that's very late stage disease too. At that stage, we'll still say you're in stage 4.
But Prof, another question I have, which I've been thinking about, why do some breast cancers grow quickly whilst others grow slowly? Like you just mentioned the cat type and the tiger type. Is it because of, say, the levels of estrogen in a person? Is it diet related, lifestyle related, or we don't know?
Okay, so that's a very good question. So what we do when you have a breast cancer, as a pathologist, when you take out the breast, you take a piece of it. Anytime they find a lump in the breast, they will take a little bit of it, okay? And that process is what they call a biopsy. And that one, they will take a part. They have different kinds of biopsy. Sometimes they will use a knife. I said that before. Sometimes they will use a small needle. Sometimes they can even use ultrasound to help them to look for the lump if the lump is very small. But the long and short of it is that they will take a bit of it. When they take a bit of it and they bring it to us as pathologists, we will look at it under the microscope first. And when we look at it, we would say, oh, yes, you know what, this is cancer. But after that, it becomes a bit more detailed. At that stage, we would ask ourselves a simple question. What is driving the growth of these cells? And that question is answered by doing another thing called immunohistochemistry. And at that point, what we will do is that we'll ask ourselves what usually drives breast cancer. And we know what usually drives breast cancer. One of them is what you mentioned, estrogen. It means that the woman's cancer is driven by the female hormones. So estrogen is driving it. It makes it grow faster. And in that case, you do the immunohistochemistry and you find that there are certain receptors. When I say receptors, it means they are receivers. It's like radio antennas on the cell that receive the signals from the woman's body that the estrogen is coming in. And the estrogen is produced by the ovaries and from peripheral conversion of fat. So if you have more fats, you convert more of it to estrogen, and then your ovaries will add up to it. So once you are producing these estrogens, which is a female hormone, the cells have these antennas on them, and then they grab these estrogen and it feeds them and they go fast. So these cancer cells have that ability to grow very fast because they have the estrogen receptors on their surface. And there's another female hormone called the progesterone, and that those cells can also, the cancer cells can also have those receptors. So in that case, you say they have progesterone receptors, and most of the time, the two go hand in hand. So if they have the estrogen receptor and progesterone receptor, it means that tumor is fed by estrogen and progesterone. Now, you may think that that's a bad thing because you're saying, oh, you know what? This cancer is driven by these hormones. So if it's in a woman, then it's going to kill the woman because the woman has the hormones. The good thing is that when you have an estrogen receptor positive cancer or a progesterone receptor positive cancer, it means that all the doctors need to do is to block those antennas that are on your cell. Find a way of blocking them so that they don't recognize the hormones you are producing anymore. And there's a drug for it. There's a drug, a very simple drug that the woman would just take and orally, and they take it and that's it. So this drug is just supposed to go and cover the antennas and prevent the cells, the cancer cells, from receiving the signals from the ovary and then the peripherally converted fat to estrogen.
So this drug will not affect the work of the endocrine system, the function of the endocrine system related to estrogen and progesterone, just that it will ensure that whatever is being secreted doesn't get to where it must hit the person.
Exactly. So it will prevent the breast cancer from growing. Of course, it's got other side effects because the estrogen is also important in other parts, but those side effects are not as profound as allowing your cancer to grow. And you'll be walked through the process of the use of a drug like tamoxifen. You'll be told that it is convenient to use it at this time instead of at this age. And this is what we opt. If it becomes necessary, they would even have more sophisticated drugs that look like that, and they will use them. A classic example is to say that, okay, you know what, why don't you just remove the ovaries? Because if a woman is postmenopausal and is already not producing much estrogen, then, I mean, taking the ovaries out may not cause any problems. That's the simplest way of thinking about it. It's the simplest way. Okay, so what is producing estrogen? Ovaries, take it out. Okay, then tumor will stop growing fast. It will slow down. But it's not only estrogen and progesterone that drives these breast cancers. There are other drivers. A good example again is what they call HER2, which is human epidermal growth factor receptor. And as the name suggests, it's a growth factor receptor. So we have our own growth factors in our body that help us grow. It makes our cells grow. But our cells have an inner clock that makes them die at a certain point in time. So if you take red blood cells as an example, in 120 days, your red blood cell, the lifespan is there. It will just die, just like a mosquito dies after some number of weeks. The same thing with our cells. The new ones will come again. That's how our body is programmed. It's the same reason why you cannot live beyond a certain age, because senescence will make your cells stop growing. But these breast cancer cells have got these HER2 receptors on them, the human epidermal growth factor receptor. And what tends to happen is that instead of having maybe a few copies, like maybe let's use an example of 10, these breast cancer cells would suddenly pack 100 of them on their surface. So when you put a small drop of growth factor in there, the cells are just going top speed. So if you identify that the woman's breast cancer has got those HER2 receptors, then you can put them on medication again. And even now in Ghana, that medication is on insurance. trastuzumab is available on the insurance. So women who have HER2 positive breast cancers can actually get that drug. So that question of what drives the cancer is actually a very good question that we have always asked ourselves. And it's one of the rules for the pathologist when it comes to treatment of these breast. The pathologist is always looking for, why is this woman's breast cancer growing? Why is it acting like a tiger? How do we bring it down to almost like a house cat? And they would go through a number of processes to arrive at that. And working with the surgeons and then the oncologist, they would arrive at a conclusion and say, okay, based on whatever you have seen, this is the best treatment for this patient. Of course, we must recognize the fact that there's a group of cancers that are not driven by any of the things that I mentioned. You test for the estrogen receptor is negative, you test for the HER2 is negative, and those are the ones that we say are triple negative breast cancers. Unfortunately, those cancers are a bit more common in our people.
So
people of African descent. Yes.
Go ahead. People of African descent.
People of African descent have more triple negative breast cancers, and these triple negative breast cancers grow faster than the average estrogen receptor positive or HER2 positive breast cancer. And our people we are Africans, and people of African descent elsewhere also have the same chances of getting triple negative breast cancer. For that one, I must say that the traditional treatment for all cancers, which is chemotherapy, which just targets all fast-growing cells, still works. In fact, those patients' cancers respond very well to chemotherapy because chemotherapy just targets fast-growing cells. And these cancers grow very fast. It's the same reason why when you have chemotherapy, some of your cells, normal cells in your body that grow fast, may be affected, like your skin, your blood vessels, or the blood itself, like your red blood cells. You may get anemic, your hair may fall off, you may have your mucosa getting ulcerated, your mouth may become ulcerated, because these cells that are in those places grow fast. Your hair grows fast. Every week you are supposed to go and get your hair shaven. And so once you are using chemotherapy, these cells would suffer because what you are doing is just targeting all fast-growing cells. But the good thing is that because those cells grow fast, when you have targeted the cancer cell and taken it out with your chemotherapy, those cells, they'll come back. So your hair goes back, and then your mucosa ulceration goes away, and then your anemia also disappears after some time, just because the cancer itself has been removed from the chemotherapy. Through the chemotherapy, the cancer is dealt with, and then your old cells can now rejuvenate themselves. And of course, you'll be aided to get your function back with medications and a diet and all that, so that you boost your own immune system and get yourself back in time.
So, Prof, no two cancers are the same. No two patients are the same. Each patient, depending on their estrogen levels, HER2, hormone receptor levels, and all those things. Every cancer is different in every person, and it takes the investigation and the transdisciplinary team to get together to decide on how to treat each case. So it's on a case-by-case level.
Exactly. So what it means is that for every person who has a breast cancer, you'd have to first look at it, type it, go on to do the hormone receptor status, grade it, stage it, and then look at the imaging. The radiologist will look at all the imaging that the patient has done to see if there's a tumor anywhere apart from the breast itself. Then you put everything together, and the whole team sits together. So you have the pathologist, the radiologist, the oncologist, the surgeon, the nurse, navigator, the psychologist. All these people sit together and they look at that individual patient and personalize the care for that patient and say, this is what you have got. This is how we are going to aid you through your journey. And that has been shown to improve outcome. The outcome is best when you do that. No the single person is going to say, I'm going to go with you this way because this is what I feel you have. No. Rather, you would have a team that decides. Yeah.
Now, Prof, we are going to end part one of the breast cancer conversation here because there's a lot to talk about. Now, on the next episode, we are going to look at breast cancer in men, and you explain the diagnostic process to us as to how breast cancer in women is diagnosed, breast cancer in men is diagnosed, and why men even get breast cancer here on the Cancer Awareness Month. Thank you so much, Prof, for the education on breast cancer. You've touched mainly on breast cancer in women today. And in the next episode, we are going to talk about breast cancer in men. And then we'll look at how to diagnose breast cancer and treatment options in Ghana as well. My name is Kojo Akoto Boateng. This has been the Cancer Awareness Month. And our guest for this morning has been Professor Kafui Akakpo, explaining what breast cancer is to us here on the show. The Super Morning Show continues. Stay with us.